Hello and welcome to the Culture Reset podcast. I'm Caroline Kenyon.
And I'm Juliette. Kumar. Hello.
In this episode, we're joined by someone who says that everything she does relates to a mission to reduce inequalities in health in the population of Cheshire and Merseyside. She is Taira Shaffi. Welcome, Taira. Do you want to introduce yourself and tell us a little bit about your role?
Thank you. Good morning, Caroline. My name is Taira. I'm the Associate Director for Organisational Design, Talent and Development, which is a bit of a mouthful, NHS Cheshire and Merseyside Integrated Care Board. I've been there now, I think, around 2 years, and my role is a vibrant, wonderful, privileged role to be in. I have two specific roles, an internal-facing role. And the best way to describe it really is I look after the cultural aspect of the organisation, the cultural health. So when the organisation, through its people, exhibits signs of distress, through its teams, or through its leadership, or through its systems and processes, then I'm the troubleshooter, if you like. I help to resolve those tensions so that we can work cohesively as an organisation. And then there's a second facet of my role, which is systems facing. And that part of the role is really responsive to creating the conditions for collaboration. Because as you'll be aware, the Health and Care Act came into effect in 2022. And the point of that was really to think about the integration of services for improved health outcomes. So my job is to help our organisations work together in that space. And create opportunities for new ways of working for better health outcomes.
So we want to hear about how you're addressing health inequalities. But first, give us a little snapshot of you. What's your background and how would you describe yourself?
Well, okay, so I am the daughter of economic migration of the 60s. So I grew up in the northwest in Lancashire in a little town called Nelson. I've spent 23 years across the public sector in the health service. And in the process of my professional career, I'm also a full-time carer. And I have spent a lot of time thankful for the services the NHS provides for us. It's been a silent partner around the dinner table for a long time. But I've also seen areas where the health service has failed our communities. And I think from a very early age, when I became a phlebotomist, just to help my mum through her healthcare needs, it gave me an insight into understanding some of the challenges that our clinicians face at the front line. And at that point, I think my father said to me, look, there's two careers, typically either law or medicine, pick one. And I never went into both of those. But what I did do was dedicate my career to ensuring that I could help improve health outcomes for our populations, not just from a moral and ethical perspective, but also from a business perspective, because, it's one of those national treasures. And we, spend a lot of time and energy and focus on protecting the NHS, and you see it in the media all the time. But when you're in it, you see how you can support it. And I think that's where I've dedicated my career. I'm a mother of two. Mm-hmm. So I've got a 19-year-old and a 17-year-old. And we currently live in Bolton, but spent a lot of time working up and down the country. Came back to the Northwest after COVID to be with family. And yeah, that's me, really.
And when we talk about health inequalities, of course, there are all sorts of barriers, aren't there, to people getting the health service that they need and they deserve. But racism in particular is one that you're very, very conscious of. Why is that? Why is that so damaging in terms of receiving or providing healthcare?
I think there is a very close relationship between race and health inequalities. And I think I've experienced that growing up. And I'll talk a little bit about that in a second, but I think for clarity, certainly for our listeners, I think when I think about health inequalities, they're avoidable. And when I say they're unavoidable, it's consequential to unwanted variation in the outcomes of care. So when I think about, for an example, my sister, take my sister as an example. I lost my sister about 10 years ago. She was a renal patient. She had kidney failure, and she was immunosuppressed. And she caught shingles. And when you catch shingles, when you're immunosuppressed, your organs shut down very, very quickly. And she was rushed into hospital. And my sister's blind from birth. So it's really important that you describe what's happening to you when you can't see the world around you because you're experiencing it through sound. And she was rushed into hospital. And she ended up in the tropical disease unit because there was an assumption that she'd come from abroad and she'd contracted a disease. And you can't help but think as a relative, in those moments that were lost, in that misconception and misunderstanding, could that have made a difference to the healthcare outcome? And we see these over and over again in terms of assumptions. You'll see it in the media with the recent Embrace report. Black women 4 times more likely to die in childbirth, 2 times more likely to give birth to a stillborn. And then I think about the experiences we have at the point of care. And it makes you think we can do better. That's unwanted variation, that's harm. And when we think about COVID, 63% of the people that died during COVID from Black and ethnic minority communities, where are we going wrong? And I guess that's the bit we've never got right. And that's the bit, it's undeniable when you think about it's an evidence-based approach, isn't it? You see the evidence and you think, where are we going wrong? And I tried to experiment with this. I spent some time with the North West Ambulance Service and I had the privilege of working with some new emergent paramedics coming into the profession, university students. And I taught a session on cultural competence for our paramedics. And it was really interesting that it was the first time they were thinking about how important your demographic profile is in experience of care. So to understand and record race allows you to develop culturally competent services, but people felt so uncomfortable about asking those questions. But those questions are critical to how you receive care. And these are the things that I want to work on because I think they will make a fundamental difference to how we experience care and the outcomes of those as well.
Yeah. Yeah, that's really interesting, Tara. And in light of the recent awful events in Southport where there was 3 children who died, there's been an increase in hate crimes, hasn't there, against Jewish and Muslim people in the UK. So, what do you think employers can do to support staff who might be affected by these events, these occurrences? And what do you think is a corporate duty to tackle racism in our organisations?
So my view would be that our organisations need to step into the space of anti-racism. And there is a fundamental difference between how we think about interpersonal racism. So this is racism that exists between 2 individuals and their interactions. And you don't tend to see a lot of overt types of racism today in organisations because we have the legislation in place. We have our public sector equality duty. And I think the NHS as a whole has developed this narrative of zero tolerance around racism. But I think in light of the stabbings and the tragedies of those and the race riots to follow, I think it's shone a light on our organisations to say you need to step into the space of dismantling structural racism. So what does that look like? So how do you explain what that is? Because it's the things that you don't see that are hidden and maintained by our systems and processes. So I'll give you an example. So take this, you mentioned the Southport stabbings and the race riots. So a lot of racial hatred and our organisations, rightly so, have said to Black and ethnic minority staff, if you feel unsafe coming into work, then stay at home. Now, on the surface, that is a really supportive strategy. But if you're experiencing social isolation or you want to go into the office, it's really easy to then isolate your Black and ethnic minority staff and say, well, stay at home, don't come out. Well, actually, what we should be saying is how do we create the conditions for you to be safe at work? And I think working with your Black and ethnic minority staff to figure out what that looks like, co-production, that is anti-racism work. And if we go deeper than that, I remember that our services are putting this wraparound care, and rightly so, around those communities and those parents whose children have suffered and seen the tragedies that have happened through the Southport stabbings. But when I asked the question, how are we addressing the racial trauma of the race riots that was, sparked, consequential to that? And how do we make sure that those families with those young children don't grow up fearing and understanding that the perpetrator is always Black? How do we address that? And how does that feature in the recovery work that we put around our families? Well, there's no straight answer around that. And once again, we forget about the implications of race when we do recovery work. And that is dismantling racism. That is anti-racism work. And that's where I think we need to focus our energies as organisations. And our organisations have got a long way to go, because you need to recognise it first. You need to see it. You need to understand it.
Do you think it takes a tragedy like this to have a leadership of any organisation think more deeply about what can be done? Do you think there needs to be something which triggers action?
I think events do trigger action. I think they shine a light. COVID shone a light on inequalities that already existed. It's not that they were created from new. They've been around, and what COVID did was amplify those inequalities. I think events have their part to play, but do I think they are the conduit for compelling action? I don't think that should be the case, and I don't think it is the case in the NHS. I think what propels the NHS to take action is when you see harm. Because if you look at medical ethics, the first principle of medicine is no harm. And racism is harm. Inequalities is harm. I think where we need to focus, and our leadership needs to focus, is in the way that we treat viruses and infections, the way that we take action against mitigating harm to patients from a medical and clinical point of view. Is the same philosophy we need to apply to tackling harm caused by racism in organisations. Not just to staff, but to our patients receiving care.
And there's something about, as a white woman myself, having worked in the NHS for over 30 years, I'm married to an Indian man, doctor, and we've got 2 children together. And there's something about the diversity of the teams at the top, the executive teams, that brings that awareness. Because when I look at organisations, more often than not, they're very white-focused executive teams. So is there work being done, or can we do work around, making those teams more diverse so that they're not so blind to these opportunities or these incidents or these systems and structures that are in place, and being able to dismantle them? Do you think that's an important part of it?
Absolutely. And I think if we look at our structures and accountability, like the Workforce Race Equality Standard, it brings into focus the snowy white peaks that we were talking about 2 decades ago. But I think we're in a different era now that compels us to diversify our boards that perhaps we didn't have before. The reason I say that is because I think we understood that we needed to diversify our boards to create awareness, but we never really understood, could quantify the value of that board. And I think now our boards are trying to understand and are actually feeling that there is a skill set missing. Optics are important because we role model, don't we, through optics. We see diverse boards, you're from diverse communities. And there was a narrative, I think, back in the 80s and 90s and even, 2001 that said, we want our organisations to represent the communities that we serve. And then there was a debate that said, well, actually, if you come from an all-white community, do you want an all-white workforce? Is that narrative fundamentally flawed? What are we saying? What we know now in the evidence is that regardless of our demographic populations and their profiles, diversity leads for better health outcomes, and that is evidence-based. So if we start there, we know that our boards, by bringing in diversity, bring in a fundamental skill set, be that ranging from cognitive diversity through to lived experience, into the boardroom to define how we respond to healthcare needs in the population, then you know that you're building responsive services. Now, at the moment, we're finding it difficult to diversify boards. So the question I'm posing to myself, my organisation, and the wider NHS is, if we know that we are missing a critical skill set, why are we not being proactive in bringing that into the boardroom? And that means we fundamentally have to change how we do governance, fundamentally change how we have to do assurance and accountability. When we talked about integrated care systems, there was a call to action on the integration of communities in our decision-making systems and processes. And when we've learned to do that behind closed doors, through through private board, through our committees, we have to dismantle some of that governance infrastructure to make room for that intelligence to seep through into the way that we work. Now, organisations have tried to do that. They've said, well, we'll develop staff networks and a race equality network, and we will lean into that race equality network to gain that knowledge and insight. But the challenge there is the power parity. You are coming into the space of ethnic minority and Black people, but actually what you need to do is open the space of decision-making to Black and ethnic minority staff so that you can work in co-production spaces. And that's the space I think we're immature in. We're still working in those vertical hierarchies, but we need to dismantle those. Now, we need to create psychological safety to do that. And I think optics for our populations create psychological safety. For our Black and ethnic minority staff, it creates psychological safety. But it's uncharted territory for our white allies. And I think that's why the heart of anti-racism work has got to be in the mobilisation of our white allies to help progress this work.
Just picking up on what you say about white allies, what I'm thinking is, if you manage to achieve that diverse leadership, if you have all the right systems and processes in place, but you're in a big organisation and that isn't reaching you, you see bad practices still happening around you, what can you do as an individual that might actually influence culture and improve things and make better decisions?
So that's the million-dollar question, isn't it? What is our personal call to action? What is our responsibility? And the way that I describe this is I talk about the difference between racism, not being racist, and anti-racist. And this will lead to the answer to the question that you've just asked, Caroline. So I think if you're racist in an organisation and you experience something. I'll give you an example. So I was sitting in a meeting a few years back, and a very senior member of staff in a meeting said, I don't want to go away on holiday and in sunshine areas. I don't like my skin going brown. I don't like the colour of brown skin. And we all sort of shuffled uncomfortably, knowing that I'm sitting right there. Now, if you say nothing as my peer, as my white ally in that space, bearing in mind that I'm mortified at this stage, then we're sitting in the racist space, because what we're doing is we're silently accepting the status quo. If you shuffle uncomfortably and you say, well, I think that's wrong. But in the moment, you don't really say anything, but you go into the corridor conversation and say, that was really uncomfortable. That was clearly wrong. I wish I'd said something. Then you're in the not racist space, because you realise that actually that was a racist comment, but I didn't say anything because it was too uncomfortable for me. But I appreciate that it shouldn't have been said. That's not racist. But the anti-racist space is when you call in the moment, you have the courage to say, what you're saying is inappropriate and unacceptable. We have peers around the table, and think about the impact of what you've just said. That is the anti-racist space, the call to action in the moment. And so many times we operate in that racist space and we accept in our organisations that that's okay, but that creates harm. It creates racial trauma. So your individual call to action should be to be in the moment, to be anti-racist, and use that language to say, can I check? Can I challenge? Can I rescue? We don't have to be confrontational, but we have to step into that space of saying, that doesn't feel right to me, and I can't accept that. So I want to challenge that and not make it somebody else's business. No, that's really scary. It's a really scary space to be in. And I think my advice to somebody at the front line, right through from somebody junior in an organisation to somebody senior, would be to develop your confidence in that space. You have to have knowledge. You have to have a level of understanding. People feel inhibited by their own language, don't they? The things that we talked about that were acceptable in race 10 years ago, it's not the language we would use today. People don't know what the right things to do. So surround yourself, learn, because you would do that if you were thinking about, I don't want to cause harm to patients. So it's the same thing. Dedicate yourself to learning and think about, well, how do I now apply this in my call to action at an individual level? And surround yourself with like-minded people.
And I think, it does take courage. And the other side of courage is to feel vulnerable, as in the words of Brené Brown. So I think there's a lot of work to do in that space, particularly with power dynamics, playing in meetings, etc. I guess what I'm saying, it's not easy, but I think we need to take steps towards that, to reaching that space where we do feel comfortable to offer feedback in the moment around what you're perceiving as harm, as you say, or perceived harm. Yeah,
absolutely. And I think vulnerability is key. And vulnerability of both on the part of people who are from Black and ethnic minority backgrounds and also people who are white. I remember sitting once in a training session and we had 2 white counterparts leading a session on race equality. And I remember sitting with a medical director at the time who was from a Black and ethnic minority background. And he said, I don't feel that you as 2 white people can talk to me about race equality. And it was really contentious because actually, and my challenge to him was, as Black and ethnic minority people working in organisations, we cannot continually be isolated in carrying the baton for race equality. We have to work side by side with our white allies and support people to step into that space. But also we cannot be held responsible for fixing the things that go wrong because of racism. And white allyship is about that call to action, stepping into space of vulnerability. And leaders do it, but it takes transformative, adaptive leadership to do that. And you're absolutely right. Brené Brown talks about vulnerability, talks about scarcity culture, and the things that get in the way of you stepping into that space.
Yeah. And you have to feel psychologically safe to do that challenge as well, haven't you? Which will apply to any bad behaviours in the workplace, won't it? If you don't feel safe in calling it out, then you won't.
Yeah.
Which might make you feel very guilty as well, because it's not something you want to do, but you feel you're putting yourself at some sort of risk.
I think it's creating a culture where feedback is part of the norm. So where you offer feedback and you receive feedback and see it as a positive or a learning opportunity. So often when you're given feedback, sometimes a knee-jerk reaction is to take it as criticism, but actually how do we create those organisational culture where we're constantly giving and receiving feedback and it's received as a learning opportunity?
I think in the work that I do, certainly in the teams that I'm involved in, we spend a lot of time trying to cultivate values-based cultures, that are based on the NHS Constitution, the Nolan Principles and the Equality Act. And I think the testament for creating psychological safety is when you can uphold those values when your organisations are in turmoil or financial difficulty or in some kind of, complex, they're surrounded with complexity and they're constantly in this reactive mode of working. But I think the work that I do in that space, whilst my teams do that invaluable work and my colleagues do that invaluable work, I spend a lot of time dismantling the current status quo. And what I mean by that is when I think about how can you create psychological safety? The first thing we can do is power parity. We can create equity. When we're sitting in our rooms around the table in a meeting, who's not around the table? Who hasn't said anything? Who have I ignored? Whose opinion isn't on the table? Have I seen this through just my own lens? And when, you're chasing the targets, it's hard to do that. But when you understand that moment of reflection will help you deliver your target and deliver your productivity, then you've got yourself a winner. So I think my first call to action around creating psychological safety is creating power parity, thinking about how do I bring skills of diversity into whether I'm sitting in the boardroom or delivering a service at the front line. I think the second thing is the optics. Psychological safety is generated. Even now, if I think about my mum goes into hospital, she looks for other Asian people in the hospital because it gives her a degree of psychological safety, because it's human nature to feel habitual and to feel safe and comfortable with what one knows. So I think investing in optics that provide psychological safety is fundamentally important. An organisation should be really visible in that space. You be asking yourself, what have I done today that embraces my support for being anti-racist? And if the answer is nothing, then you've not stepped into the space. It's an everyday thing. And I think my third possible move into psychological safety is accountability. Without accountability for race and without accountability for tackling racism, then you're on really, really delicate territory when you think about your relationship with harm. And I think if our medical ethics can push no harm through the NHS, then we need to see racism through the same lens, and our accountability through our interpersonal interaction, as well as the systems and processes we design, needs to hold visible accountability. It makes me think as a Black and ethnic minority staff, you take this seriously. But it makes you, as a white ally, think, I've taken this seriously. And I think that's the space we need to be.
So finally, Taira, what you said has been so insightful and so interesting. But if you were going to just round up and leave us with one piece of advice you would give to an individual who really wants to change the culture, doesn't know how or where to start, what would be your one piece of advice?
I think the piece of advice that I'd give this piece of my advice to my children, and I trust them with it. So I think this is the same advice that I would give to anybody working in an organisation. Well, I would say be curious. To tackle racism does not come through confrontation. To tackle and address racism comes through curiosity. It comes through challenge that is safe and psychologically safe. And to do that, be inquisitive, understand people's perspectives, and frame them in a way that allows you to challenge, but keep yourself safe in doing that as well. And have allies, have people, surround yourself with allies and people who can provide you with air cover when you question and you are inquisitive. I think that would be my advice.
I like that. Thank you, Taira. Be curious. I love it. Well, thank you, Taira Shaffi. We have to stop it there. Thank you so much for joining Culture Reset. And thank you for listening. If you'd like to find out more about how to create a healthy workplace culture and about what's happening in Cheshire and Merseyside, there are links in the podcast notes. Until next time, it's goodbye from me, Caroline Kenyon.
And from me, Juliette Kumar.
Goodbye.
Goodbye.